Okay, so last week we looked at the pelvis, and we said that the pelvis and the hip are inseparable. Just like when we looked at the shoulder girdle, we looked at the scapula and the humerus. And although we visually see the humerus moving, it's really the humerus doesn't move independently of the scapula. The scapula is what provides the stability or the platform for the shoulder to move. And the lower extremity, when we look at the appendicular skeleton of the femur moving, same thing. The femur, its course of action is really predicated on the pelvic positioning. And unlike the shoulder girdle was independent of the spine because each scapula was able to move independently of each other, whereas the pelvis has that semi-fused relationship through the sacrum, through that SI joint. And so if that SI joint is, especially if it's not through the sagittal plane, it's more in the frontal or the transverse plane, where the pelvis goes, where one side of the pelvis goes, the other side goes as well. So if I get a left hip hike, so if I hike up my left side, my right side's going to depress. If I rotate to the left, my pelvis turns to the left, it's going to be an obligatory movement for that right half to go back. We didn't have that in the upper extremity through the shoulder girdle because the scapula were able to move independently of each other. They were more predicated on the thoracic spine. So if you went into flexion or extension, you would change the tilt or the angle of the pelvis or of the scapula. So when we go down to the pelvic girdle, it's hard to have a conversation of the hip itself without really being considered with the pelvis. So we talked about the pelvis. The big takeaways from there were the anterior posterior pelvic tilt and the coupled motions of hip hike and so forth. And then that pelvic tilting, that anterior posterior pelvic tilt, isn't just a function of the hip, which we're going to talk about today. It's also a function of the lumbar spine, which we'll talk about in the next unit. So when we look at the hip here, you can see the femur and you can see the socket there. And that's a big difference between the shoulder girdle and the pelvic girdle, is that there's a huge amount of bony architecture here that encapsulates that head of the femur. And that's because we are load bearing through the lower extremity. We didn't have that in the upper extremity because we're not normally walking on our arms and we're only crawling for a few months at a time. So you have a very shallow socket for the head of the humerus to fit into the glenoid fossa. You have a very deep socket when you're looking at the acetabulum and you're looking at that labrum around the hip, for that femur to sit into. And I usually ask this question during class and lecture: is if I were to poll our class and I would ask how many people could do the splits, maybe a random two people might raise their hand, right? Or it would be a conversation that they could. If I ask the same question about the shoulder girdle, how many people can bring their arms over their head and connect them to the top? There might be one person that couldn't do that, and that's because they're in an acute injury or some kind of pain right now. So we have significantly more mobility in the upper extremity than we did in the lower extremity. So, and the reason why that is that we have a lot of structural stability in this pelvis. And let me see if I can. No, this book is not showing it here, but if you look here from the lateral view, you see the acetabulum there, and that's the union of the ilium, the ischium, and the pubis, the three bones that make up the pelvis, and you have a labrum ring that goes around there, and that socket, that head of the femur, sits really deeply into that socket. So it doesn't rely on structural stability like the upper extremity did. It has a lot of passive stability. It doesn't rely on the muscle. And we looked at the ligamentous structure in the posterior aspect in the hip last week, or in the pelvis, and we were looking at those load transfers, more so transferring load from the left lower extremity up into the right side of the body, and vice versa, the right lower extremity transferring those loads up to the left side of the body. So you do have a pretty stable hip. You'll inevitably dealing with people that have had a hip replacement, and if you ever have a chance to sit in on a surgery, which you might be able to do during your clinical rotations, I don't know in this current climate, but if you ever have an opportunity to sit in on a surgery, a relationship with a surgeon that you're working with, they're always open to having people come in. And if you the way that they take the hip, the old degenerative hip, out of socket, they actually have to pop it out, and it makes like an audible pop when it comes out, because there's so much suction in there from that fluid that hip's not really going anywhere. So hip dislocations are very, very rare. They're possible, but usually high velocity. high force output. Shoulder dislocations are actually pretty common because of the lack of stability there. So the bony architecture there is pretty good. So most of the musculature. So remember we talked about the the shoulder rotator cuff as more of a method to keep that compression, to keep that glenoid fossa really tight against that with the head of the humerus. You don't really have that muscle responsibility or need down in the lower extremity. In fact, you have almost no direct internal hip rotation muscles down at the hip. Almost all of the hip rotators down there are external, and they're there for more fine control, and they're more for loading to distribute force for controlling eccentric loading than they are for actually producing external hip rotation. And they're definitely not there for stability because the stability is being meant by just the nature of the structure of that hip capsule. Let's see here. Is this okay? So those are your movements, and I think we talked about the hip movements there last week. You have hip flexion, but remember this is hip flexion of the lower extremity moving relative to the pelvis. You can also produce hip flexion with the foot and closed chain where the foot's on the ground, and that's the pelvis moving relative to the femur. And next week, Tuesday, I'll actually take the skeleton or the model, Tuesday and Friday, and we'll actually show how that's looking so you can actually appreciate the approximation that the pelvis is making in that pelvic tilt, which is the same as hip flexion, or posterior pelvic tilt, which is the same as hip extension. You have your internal external rotation and abduction. So this is just like the shoulder. It has 3 degrees of freedom, so it has movement in all 3 planes. And it is also one of the other joints that can do that circumduction, that circular movement where the proximal end is relatively stable and the distal end is making a circle or a loop with the extremity. So here's your structure of the bone. We're going to look at the proximal end now at the hip, and then next week we'll look at the distal end when we look at the knee. But when you look at the proximal end, you can see that very little, if any, muscular attachment is right here on the femoral neck. So when we look at the femoral neck here, so this here is what's embedded into the pelvis and into the acetabulum, and then you have the connective tissue here, and the joint capsule comes pretty far. It comes all the way up almost into that neck. Almost all the muscle attachments are on these 2 items right here. This is the greater trochanter, and you have the lesser trochanter. So the trochanters here are the primary attachment sites or anchors for those muscles. On the greater trochanter, you have your glute minimus, glute medius, and only part, if any, of the glute max. The glute max mostly attaches into the IT band, but we'll talk about that in a moment. Then you have your lesser trochanter here, and the most important muscle that attaches here is the iliacus and the psoas. And the iliacus and the psoas muscles, they originate as 2 different muscles. You have the psoas that's starting on the lumbar spine, and then you have the iliacus, which is on the ilium, and they both come down and converge, and they attach right here on the lesser trochanter. And then between here and down the rest of the shaft of the femur is you have your quadriceps, your hamstrings, and your adductor muscles, which make up the bulk. We'll talk more about the quadriceps and the hamstrings in the knee, but we'll look at the adductors today. This linea aspera here, this is on the posterior aspect. This is the back of the leg. Now just follow me for a second. This is the back of the leg, but it's where most of the quadricep muscles originate from. So the quadriceps, we always think of an anterior muscle, but they actually start from behind and kind of wrap around to the front of the femur and then come down to a central tendon, to the patellar tendon in the knee. So this usually tricks up or confuses some students. Think of it as, I'm trying to figure out how to, if you were to take your hands around the femur there, the quadriceps start from the back and then wrap around from that way. It just gives the muscle a little bit more length. But there's really not a lot that attaches on the front of the femur. There's a lot of muscle bulk and muscle mass there, but there's not a lot of attachment. Most of the attachment is on the posterior aspect of the leg or around a little bit on the inside where the adductors. But even like the Abductor Magnus, the adductors, they attach through this linea aspera. So this is actually raised on the bone, on the femur itself because of the forces that are being generated from that. So just think, even though it's anterior musculature for the quadriceps, it's originating from behind. Here's your posterior or your distal aspect of the condyles and the articulations with the knee, but we'll talk about the knee next week. So here you can kind of appreciate how I was saying, like, here's your greater trochanter right there, and your lesser trochanter's popping out behind there. You can see how much of this is actually ligamentous structure and joint capsule. So although you see this protruding femur here, this head of the, like, almost none of this is exposed. This is all wrapped in a really tight, dense joint capsule to keep everything in alignment. And then most of your musculature is originating right on the outside there. So you have your three primary ligaments. You have your anterior iliofemoral ligament, and the way that these ligaments are labeled is based on where they're originating and where they're going. So the iliofemoral, it's going to the femur. That's where femorals come from, and ilio is referring to ilium, so the iliac version of the pelvis, the one bone. You have your pubofemoral, so that's coming from the pubic symphysis to the femur. And then in the posterior aspect, you have your ischiofemoral ligament, and so it's coming from the ischium and then going to the femur. So those are your three ligaments. You happen to have three bones of the body, or three bones that fuse to make the pelvis, and just keep track that the iliofemoral is coming from the ilium, the pubofemoral is originating at the pubis, and the ischiofemoral is coming from the ischial bone. And then I don't know in your ortho classes if you guys are getting into precautions, like you still have some surgeons that are doing posterior hip replacements. And although the progressive or the new way is the anterior, that was the new way where we didn't have any of these hip precautions. A lot of the surgeons, especially the minimal surgeries, they're only making incisions about that big, maybe 3 or 4 inches. And they're going back to almost not a posterior approach, but they're going to this quasi-posterior approach. But anyways, when they get in here, what they do is they have to cut through this ligament structure to get into the joint capsule. So they cut that open and they basically pull the hip out and they flip it back so they can cut that off and then put the prosthetic on. And what can happen is if you go into too much hip flexion or adduction or internal rotation, this posterior ligament here, what can happen is, let's say my fist right here, if you can see that, is let's say that's the femoral neck, the head of the femur. This is the shaft, and then there's like my greater trochanter here, and then my hand here cupping makes the acetabulum. So if let's say for you guys, this would be a left leg. If I go into internal rotation, you can see that the head of the femur is actually presenting as facing you. If I go into adduction, it's kind of coming here. And if I go into hip flexion, it's doing that. And if I do all three at the same time, because that ligament usually acts as a sling and keeps that nice and congruent and keeps everything in. But since they cut through that and they have to allow 6 weeks for that to heal, that can pop out and you can end up with a pretty nasty dislocation. Anytime someone has a traumatic fall and they fracture their hip, 9 times out of 10, the doctor, even if he's an expert in anterior hip replacements, usually when they have to do a traumatic hip replacement following a fall, 9 times out of 10, it's a posterior hip replacement, and you can count on it that it's going to have posterior hip precautions. Even if they do an anterior approach, because of the fracture and the nature of the bone, they usually will put posterior hip precautions on for a couple weeks, at least 3 weeks, maybe longer. And what the posterior hip precautions are no internal rotation, no hip flexion past 90 degrees, and no hip adduction, so no going cross midline. If you guys haven't had this yet in your ortho class or your techniques, it's going to be, this is one of the biggest things that, like, when someone comes out of surgery, the first thing you always want to find out is their weight bearing status. Are they full weight bearing, partial weight bearing, and so forth? The other thing is, are there any movement restrictions? And those, as a physical therapist, when you're working in a subacute setting or an acute hospital setting, those are the very first things you're looking at is weight bearing status and hip, if there's any type of movement restriction or precautions. People coming out of cardiac surgery, they'll have sternal precautions where they're not able to put weight through their arms, and so that if someone is relying on their upper extremity. But again, these will come things in your ortho class, but we will discuss this in some of the issues here, particularly hip replacements, because it is, I don't know which one's more common, hip replacements or knee replacements, but is the number one orthopedic surgery you'll be dealing with. The hips, knees, then spinal surgery, and then some like wrist fractures, like arm tibia fractures and bone fractures, and then shoulder replacements. I think in my entire professional career so far, I've only dealt with one patient with a shoulder replacement. They're just not done that often But hips and knees, I mean, we're doing a couple a week, and I'm just a registry physical therapist, so I don't work that often, but at least once a week I'm getting at least one knee, one hip, and so it's just the most common joint surgery. And I don't know if you guys are up to it, but these surgeries now that used to be so dramatic, you were months in the hospital, are now being done in an outpatient day surgery. So you're going in day of, getting surgery done, and then you're discharged the very same day home to do your recovery. That's how minimal the surgeries are, and how congruent and how great the prosthetics are. So it's kind of cool where they're going with all this. Anyways, that was a big long tangent on the anterior ligament structure and the posterior ligament structure. But the one to keep in mind is when they do a posterior approach hip replacement, this is the ligament that's being cut, and then they got to wait for this to heal before a patient can bend over and pick something off the floor or cross their legs or even move forward to sit up out of a chair. So here's some ligaments here. I do want to show the IT band, so I'll find some images on Google that will look at that better. But one of the ligaments here that comes up, and this will be a big ligament when we talk about the trunk and spine, is the inguinal ligament. And this basically forms the floor or the bottom of the abdominal wall. And so your transverse abdominis, your external oblique, internal oblique, all of them come in and attach down here. And you can see there's a little bit of a gapping opening here. And when someone gets an inguinal hernia, it's usually because of a defect in the abdominal wall through here, because this is mostly connective tissue, and then above that you have your musculature. But it serves as an anchor point or reference point when we do our surface anatomy, the inguinal crease that's created here. But that anchor is right at the ASIS, the anterior superior iliac spine, and that was when we talked about the pelvis last week. That's the one point that has to be in the appropriate plane with the pubic symphysis right here for you to be considered a neutral pelvis. So your ASIS is the anterior superior iliac spine, and then you have an AIIS, which is going to come up here, which is the anchor for your rectus femoris. The IT band. Okay, so cool. Here is your psoas, and you can see that originating at the lumbar spine here. And then here's your iliacus muscle that's originating on the internal surface of the ilium. And then they converge down into one tendon, and it attaches right there at the lesser tubercle. Your rectus femoris here is so right above here is the ASIS, the anterior superior iliac spine, and as I just got done saying, the origination for the rec fem is the AIIS, or the anterior inferior iliac spine. And really, these iliac spines, they're usually done as acronyms. So AIIS in this case. It's just as if the pelvis comes up and you had a crest on the pelvis where the bones are kind of coming out. So let's say I'm reaching up from underneath and I had a bowl in my hand and I'm grabbing the pelvis. I'd be wrapping my fingers around the crest of the ilium on both sides there. And if you take your hands and you put them in on your side and you push down, you'll be putting pressure right on the crest of the ilium. You know what? I'm talking like this. Let's just pull it up. I have the whole internet in my accessibility here, and I can pull up an image in seconds. So right here is the top of the pelvis, and that's called the crest. And this is the part of the ilium, and they call this a wing, because it kind of wings out. If you were to look at this like a butterfly or a bird, so this is the flared part, and so this is the very top, and on the inside of this right here, this is where your iliacus muscle originates. So the entire surface here is filled with muscle. Think of it as a similarity to how the subscapularis was to the scapula. It just fills in the entire basin. Right at the top here is where a lot of your abdominal musculature originates, or either originates or inserts, depending upon if you're talking about the obliquus internus or externus. But your transverse abdominis, your internal oblique, external oblique, at first it's like a sandwich. It goes iliacus, and then it goes the oblique musculature, and then right on the outside of that, because this is not very big, but you have these thick, bulky muscles, starts your glute medius. And then underneath there, if we were to look at another view, which we'll see glute minimus, but it really is iliacus, oblique abdominal wall, and then your abductor muscles, or your glute medius, or your primary. And then right in front, if you were coming to if you were to see on top, if you come in front, right here, this protrusion, which you can palpate. If you reach down, you can palpate this pretty easily. That's your ASIS, your anterior superior iliac spine, so the one that's in front on top. And then your AIIS, the one right below that, this is down here. And this is hard to find. If you start digging in and around here, you kind of have to go through the tendon of your iliac, of your rectus femoris. And so it's a little harder to palpate. But right here is where your rectus femoris originates. And there's a little bit of the attachment right here. Let me see if I can pull this up. Let's go view image and zoom in. Yeah, perfect. So right here is the ASIS that's easily palpable, and that was the one that we talked about. It has to be in the proper plane with the pubic tubercle, the pubic symphysis in the front here. And if it was too far forward, that'd be an anterior pelvic tilt, and if it was too far backwards, it'd be a posterior pelvic tilt. And then right below here is the AIIS, the anterior inferior iliac spine, and it has the origination of the rectus femoris. But the rectus femoris also has a little bit of attachment down here on the ischium, right down here, right before it becomes the pubis. And as you can see, the rectus femoris, it crosses the hip. So it's a hip flexor, and it's also one of the 4 muscles that make up the quadricep. So the quadricep is 4, and like I said, we'll talk more about it. The 3 muscles, vastus medialis, vastus lateralis, and vastus intermedius, they're monoarticulate muscles, meaning that they only cross the knee. So they have no function of the hip, but they do knee extension. Rectus femoris also does knee extension, but it crosses the hip as well. So it is a biarticulate muscle, and so its force production, because of passive or active insufficiency, is dependent upon knee position if you're looking at the hip, or hip position if you're looking at the knee. It is one of the 3 or 4 muscles that do hip flexion. So it's one of those muscles that come into conversation a lot to test your knowledge on, do you understand active and passive insufficiency? So if you wanted to get a full shortened position of that, you would have to take in consideration both knee and hip. We will talk more about it with knee, because we'll look at it as a knee extensor, but we'll talk about its influence in knee extension based on starting hip position. It's a good image. So then again, right here is your lesser trochanter. So what was happening was your iliacus was coming down here, originating. Your psoas was coming up here from the spine, hitting these bodies of the vertebra and these transverse processes. They come down, they converge right below the pubic symphysis, and then they converge right down here. And this kind of has a posterior attachment. So it's not quite in the front, but you would see it clearly if we looked at a posterior view for this. So if let me pull up my little marking. All right, so if I have my iliacus and my psoas, they're both converged down. There's really no separate attachment here. It's one common tendon at this point. That's why it's referred to as the iliopsoas. When it's up here, oops, what's going on? How do I scroll up? Oh, because I gotta go here first. Okay. So if I go up here and I look at my musculature, my psoas is coming down this way and my iliacus is coming this way. They are clearly 2 different muscles. Like you can clearly palpate and dissect out the psoas musculature, and you can palpate and dissect out the iliacus. But as you start to go further down, they become one tendon, and where that happens, it's unknown. It's whether here or here, but by the time it gets to this point, it's one tendon coming down that way. So when you're really referring to the iliopsoas, it's referring to the common tendon down here, but they are 2 separate, innervated, and distinct muscle tissues that are above, or when you get more of the proximal attachments. But what I was saying earlier is this lesser trochanter has more of a posterior aspect. So what ends up happening, if I pull on this here, it is clearly, you can see, hopefully you can see that it does hip flexion, right? If it pulls up this way, it's going to bring the femur forward, and that would approximate the femur towards so it's hip flexion. But what it also does is, this is more of a posterior attachment, it's going to turn, it's actually going to rotate. So the bone's actually going to go this way. And so it's a pretty powerful external hip rotator. So it does external hip rotation and it does hip flexion. So those are your hip flexors, but they also do external hip rotation. What we're going to find is that we have tons of muscles that do external hip rotation, and we have very few little muscles that do internal hip rotation. And a lot of this has to do with the way we're loaded with gravity. If gravity takes over, our body weight naturally goes into internal hip rotation, hip flexion, and adduction. So the only times we really need to perform internal hip rotation actively is when we're in anti-gravity situations, which is very far and few in between. So when you're laying on your back, or when you are, I'm trying to think, like, there's really not that many situations where you're in anti-gravity. Most of your life, like from infancy on, you're doing nothing more than trying to get up to stand, and the mere act of standing is nothing more than anti-gravity. So your body has to actively produce external hip rotation to do that. And then every time you take a step, you are collapsing with gravity, and your body's counteracting the effects of gravity. So we really have there's no muscle that does direct internal hip rotation. Everything we're going to look at has maybe a little function, like your tensor fascia lata, which we'll talk about in a second here, is an internal hip rotator, and maybe some of your glute medius fibers, which are mostly hip abductors. They have a function for internal rotation, but internal rotation is not a normal muscular function that we do at the hip, because gravity is doing it automatically, and everything we're doing is like anti-gravity, right? It'd be like having a dam prevent water coming in, and you had a pump there that would pump water in the direction you're trying to keep out. You would use that so infrequently and maybe only in emergency situations, but everything the body's doing is external rotation. So when in doubt on an exam, if given the option, external rotation is probably the option. And as long as you know those like 2 or 3 muscles that have a function in internal rotation, you'll be fine. So just a heads up with external and internal hip rotation at the hip. Okay, back to this guy here. Nope. So as you can see here, the rectus, that's not the rectus femoris. This is Sartorius rectus femoris, yeah. As you can see here, rec fem comes down, and it's one of the 4 muscles of the quad. It hits the patellar tendon, and then it has the common attachment down here at the tibial tuberosity. Your sartorius muscle is, it's usually considered the longest. It's always labeled as the longest muscle of the body, and it attaches at the ASIS, so that really palpable hip right below that, and it comes all the way down and actually attaches kind of almost like a posterior attachment, but comes down and heads to the front here at the what's called the pes and serine. And hopefully there's a let's do this then. Let's pull up sartorius. So pes and serine, I want to get the words for you because it's hard to hear it, but it stands for goose foot, is the Latin, some kind of Latin aspect of it. But it's the common attachment for the sartorius muscle, the gracilis, and one of the hamstrings, the semitendinosus. And it's actually an anterior attachment. So this is where you get this weird aspect that you have the hamstrings, most people know your hamstrings are in the posterior of the leg, but one of the hamstring muscles, the semitendinosus, actually comes around to the front on the tibia, which has this common attachment site. So if you start to look through this pes and serine, and again, these are great anatomy questions, like what are the 3 muscles that attach at this common aspect, right? So like iliopsoas, they converge down into one tendon. These 3 muscles, sartorius, gracilis, and semitendinosus, it's not as pronounced, but they originate, they insert at this common aspect called the pes and serine. And the reason that, if you look at a goose foot, it's like a 3-pronged, like a heel, the two toes, if you will. But those are how the 3 muscles attach in down there. But it is, let's see if we can find a good photo of it. You can kind of see it right here. So here's your sartorius muscle. So this is a left leg looking at a lateral view. So here's your this is your quadricep complex. Here's your rectus femoris right there. And then here's the posterior part of the leg back here. And you can see the 3 muscles coming down here and making that like triad here of that pes and serine. You have your sartorius, which is coming forward. You have your gracilis, which is one of the adductors, which we'll talk about in a moment. And then you have your semitendinosus, which is one of the hamstring muscles. And so the sartorius will be involved in knee flexion. And it's called the Taylor's muscle, the sartorius, because it does this combination. Let's see if we just do hip external rotation with abduction and knee flexion. Let's see what comes up. Let's see if Google gets it. Yeah, right there. Perfect. So it does this. If you were to make a figure 4 with your leg, this motion right here where you see this hip, a little bit of hip flexion, you're getting some hip abduction and you're getting external hip rotation. That's because sartorius, let's see if it's coming straight down here and it's attaching right there at that pes and serine. And so it's trying to shorten that. So if you take your right heel and you put it on the front of your left shin and you try to bring your leg up like this figure 4, that is the exact function of what the sartorius muscle does. And it's called the tailor's muscle because apparently tailors would kind of cross their leg over like that when they're sewing and holding their object. I don't know. I've never sewed before, so I don't know. But it's called the tailor's muscle for that reason. But this figure 4 function, this is the exact muscle function of the sartorius. So you can see there, and it's coming down, and then it's it's in front of, because it goes the sartorius. Then you have the gracilis muscle, and then and that's right there. And so if this attaches up, it's going to take the bone and pull up this way. So that means the knee's going to come up this way, and the foot's going to come around. So again, external rotation, hip flexion, and hip abduction, abduction. Why does it go all over the place here? Okay. All right, so the hip flexors were there. Now we're starting to get into the hip adductors. The pectineus muscle, it's a smallest adductor, but it does involve a little bit in hip flexion. So you can see the pectineus right here. And it is, when you see the dashed line there, it's going behind the femur a little bit, but it's an adductor muscle, but it's really close to the pubic symphysis, so kind of in the groin area. It's one of the only adductors that attaches up here on the ramus of the pubis. So it does have a little bit of a moment arm for hip flexion. It can do a little bit of external rotation, like most of these adductors are going to do. But the adductor function, and so if you read, let's see, what does it say it does here? Let's make sure it doesn't. Now remember, if you were taking this class and you were learning these muscles in anatomy, you always learned them from static position. So you learn, and so the reason why I'm talking about the adductors now as the pectineus is like I said, it's a transition from hip flexion to hip adduction. And the hip adductors, as you would expect in their name, they do hip adduction, adduction, but that is only when you're in a static position, an anatomical position. Think about the amount of times that you're in that position, which is very rarely. And the adductors are one of those muscles that, depending upon the starting position of the femur, their function changes. The only thing the adductors cannot do is abduction. So there's never a situation where the adductors can be abductors. So there's never a situation where the adductors can be AB or abductors. But depending upon your starting position of your femur, your adductors can do flexion. They can also do extension. They obviously can do adduction. And then depending upon where they're at, they can do either internal or external rotation. And again, all depending upon starting position. So you look at a group of muscles that are always working to kind of stabilize the hip. If the hip had a rotator cuff, it would be the adductors. It's the muscles that are kind of keeping that leg in the same plane. And it's one of those muscles that it's not used so much when your foot's off the ground. It's usually one of those muscles where your foot's on the ground. And if you were to stand up and just pick one leg up, what would happen here? Let's pull up an image here. Oops. Yeah, let's just pick this guy here real quick. All right. Let's do this real quick. See. There we go. Perfect. All right. So when you stand and you pick up one leg and you're standing here, what wants to happen is gravity wants to drop down like this. And so this is referred to as Trendelenburg. And under normal motor control and tissue muscle strength, when you pick up one leg, your pelvis automatically, when it senses that, in order to correct your balance, you shorten your base of support from 2 feet down to 1 foot. And so you actually do a little bit of a shift to the single leg, and your pelvis stays neutral, right? And your pelvis is always trying to stay neutral because during gait, it needs to make sure your foot can clear. If you walk and you pick up one leg off the ground and your foot and your pelvis drops down like this image right here, your toe clearance gets restricted and you're going to trip. So automatically when you pick this leg up, the muscle activity kicks in, and what's actually happening are the adductors you're getting abductors on this side and adductors on this side to keep that leg stable and in check. So your ab and adductors really come into play. It's not so much with you're not so much looking at this leg that's in the air. It's always looking at the stability of the posting leg, and you want to make sure that your pelvis stays relatively level when you are either single leg stance or walking. And this is a function of hip abductors on this side and the adductors on that side. So don't think of the adductors as them bringing the leg in towards midline. The adductors and abductors are mostly working to keep your pelvis neutral, whether your left leg's on the ground and your right leg's up, or your right leg's on the ground and your left leg is up. So think of them in terms of that closed chain type function when we looked at that. But if this Trendelenburg is when you see this hip drop happening, and so if you see this during like a posture exam, or you're seeing a patient and you're having them do like a single leg stance or single leg squat, which is a really great assessment tool, you'll see a lot of weird things happening. You'll either see knee dysfunction when you'll see the knee diving in, or you'll see one pelvis dropping down, and that's either a neurological weakness, or if it's not and the nervous system is fine, that's a musculoskeletal weakness that needs to be addressed with some kind of exercise intervention. All right, so the pectineus is one of the adductors, and then you have your adductor brevis and adductor longus. And when you see brevis, it usually means the smaller the two muscles than when you see longus. So you have adductor longus, which the name implies what it is, and adductor brevis is another way of saying adductus shortus, but shortus is not a real muscle. But so here's your adductor brevis, and then right below that is your adductor longus. They have a very similar connection. There is let's pull up that image of the adductor tubercle right here. So here's your pubic tubercle right here, and you have your ischial tuberosity down here, and you kind of have this pubic arch. And right here, this bridge, this is where, and it's called the pectineal line. That's where the pectineus originates. So the pectineus is coming down from here, and it's shooting straight down. It's a short little gap to kind of cover that from there to there. And then as you move down from adductor brevis to adductor longus and eventually adductor magnus, you're going to start down the chain here. You're going to do adductor brevis, adductor longus, and the adductor magnus. And the adductor magnus, and then right here, this is where your hamstrings would start. So you kind of have your pectineus, you have your adductor group right there, and then you have your adductor magnus as kind of transitions in. And adductor magnus, as we'll talk about in a second here, has an adductor division, and then has a hamstring, so it's almost as functional as a hamstring. And a lot of times when people say that they pulled their hamstring, a lot of times they're pulling their adductor magnus muscle. So as I said, we'll get to that in a moment, but what I want you to appreciate here is that everything is kind of in this tight little area. Let me see if I can freehand draw. There's your pectineus there. There's your adductor brevis, adductor longus, and then your adductor magnus. And so it's like this little C shape here, and then right down here are your hamstrings, and that kind of covers that entire ischial capsule there. And then all of these are inserting down through that linea aspera that we looked at before. Not the linea aspera, the linea aspera. Let me get back to that image. So when we looked at the femur before, when we looked at the structure, right here, that linea aspera, this is the common site here. Oops, that's way big. So this is the common attachment site where all these adductors are coming in. So you have pectineus that's kind of around the front here a little bit right there, and then adductor brevis, adductor longus, and adductor magnus. And then right next to them are the vastus medialis, vastus lateralis that are coming around to the front of the muscle. So you got a lot of stuff happening here that's attaching. Okay, so your adductor brevis, and then that's your adductor longus, and then right here is your adductor brevis. And you kind of see they overlap a little bit, but that's like here would be the brevis right here. That's your brevis attachment. That's your longus attachment, right? There's a little bit of overlap, but they're one continuous sheet. And then right here you can see the adductor magnus, which kind of forms the entire backdrop. It's like the floor of the adductor complex. And so it's obviously called the magnus because it's so big. It's the third largest muscle of the body, behind the glute, and then lat, and then the adductor magnus. It's huge, right? And it's got two divisions, which you're only seeing the horizontal fibers right here, or sometimes referred to as the adductor division. Hopefully the next image shows. Yep. And then so you have this adductor magnus, and it's got two separate divisions. It's not two separate muscles. It's still the same muscle, but you have what's called either the adductor portion or the horizontal fibers, even though some of these fibers are going vertical. And then the next image you're going to see here are the vertical fibers, which are right. No, this is Gracilis here. Okay, this book sucks. Let's go to the. Okay. So your book is showing it as the same. So let's go back up to the image here. That's why is it so big here? Okay, let's see this. So you can see that these fibers are, let's get different colors so they come up a little better. Okay. So you can see these fibers here kind of have a oblique type obliqueness to them. All the fibers are originating and they're eventually coming back to here. And then when you get way here medially, a lot of these fibers, that's not a good line here. Let's do this. A lot of these fibers have like a linear or vertical orientation. And so you have this horizontal division. And if we drew these as arrows, you would appreciate this better for this line of pull. And you can see how the horizontal fibers, if you were to look at this from anatomical, are your adducting aspect. And then if you look at these vertical fibers, you would see that these fibers here that are kind of moving more in this vertical aspect, they're going to do more of a hip extension. They're going to be more like hamstrings. So that's why you get your hamstring portion or your vertical fibers. And then you have these fibers here that are kind of running horizontally that are more of your adductor. So it's not that you would clearly separate these out, but what you appreciate is that this huge sheet of muscle, which is a large muscle lower body, it has this adduction component and this extension. And a lot of times when people pull a groin muscle or they pull a hamstring, it's sometimes inseparable. It's usually because it's this muscle here, and it's probably a tear that's happening or a strain that happened kind of right at that transition, maybe in the middle over here. Very rarely do you get like these adductor strings, but a lot of times you do get these vertical fiber for the hamstring aspect, right? So just keep in mind, I thought there was an image for that, but let's go back to that other image that I pulled up. You can kind of see that flap here. You can see the horizontal fibers there, these oblique fibers. And you can kind of appreciate those vertical fibers right there. So again, it doesn't cross the knee, so it doesn't have any kind of knee function like the hamstrings do, but it definitely crosses the hip, and it can do hip extension. So the Adductor Magnus can do hip extension. You can kind of see here, you can see all of them now. You can see pectineus. So this is a posterior view that you're looking at. And you can see the pectineus is more of that front because it does hip flexion. But then you can see adductor brevis, then you can see adductor longus, then you can see adductor magnus, the horizontal fibers. And then this tendon right here, that is the vertical component. So that's just continuation of the adductor magnus. And then right next to the one we're going to talk about next is the gracilis, which is one of those other muscles that goes in with the pes anserine and the Sartorius muscle. So here's your gracilis. It's the last muscle that attaches up at that pubic tubercle. So you kind of got the C-shaped here. This one's a little bit more in the front, so it can do a little bit of hip flexion, but it comes down and it is a knee flexor, right? It kind of comes down and around and right there at the pes anserine. The exact same attachment where the semitendinosus and the sartorius attach. So now we start getting into the big hip muscles of the hip extensors. And you have glute max, which is the largest muscle of the body. And what's fascinating about the glute max is that only about half of its attachment is actually bony. So what happens here is that all of this is along the, you have a little bit of the ilium, you have a sacral origination, and you have a coxal origination. So you really have three divisions of the glute max. I mean, there's so much muscle here, and there's so much bulk, but you have an ischial division, which are these fibers up here. You have a sacral division, which are down here. So the origination is 100% into bone. Now, when you look at the insertion down here, here's your greater trochanter, and you have a little bit of the posterior aspect. Here's your greater trochanter there. Anywhere between 40 to 60% attaches to the bone. The rest of it down here, this more inferior attachment, is 100%, or not 100%, but it's not bony at all. It's into the fascia of the leg. And that fascia over time, when it pulls on there, becomes the iliotibial band, the IT band. So the only reason that IT band is IT band, if we look at anatomical if we look at anatomical dissections of this, of the IT band, we always see it dissected out as this like nice, perfect line right here, right? Like this, you see this line, you see this line. Well, this is false. This is just a presentation. It's like they decided to cut that out. If you look at if we look at the thigh itself, we look at a cross-section of the thigh, encompassing this entire musculature, underneath the adipose layer, the subcutaneous fat, and just on the outside of muscle, you have a fascia, and this fascial envelope is like, think of it as saran wrap that's wrapping around the tissue. And it is continuous all the way around. What happens over time, because of the way the glute max comes in, and you can kind of see, let's get a good view here. That's a good one right here. So you can kind of see the glute max right here, and you can see here's your IT band. This is the leg fascia, and they kind of cut away some of this image. Actually sucks. Let's get another one. Here we go. This glute max comes in and attaches to that leg fascia. And then what happens over time, because of all the standing and happening, that fascia gets a little thicker. So it's not that this it's not like a tendon you can find, like a patellar tendon or Achilles tendon. What it is when they were doing that dissection, they just cut away at the thickening of that fascia, but the fascia is really around the entire leg. So when the glute max contracts and it pulls, it doesn't pull right on this little tendon. It's pulling on the entire thigh. It's pulling on that big bag, that envelope that's holding the leg, and it's pulling that entire thing posteriorly. On the front here, on the other side, you see this muscle called the TFL, or the tensor fascia lata. And this muscle originates right behind the sartorius. It's right behind, right at that ASIS. And it comes down, and it has 100% of its attachment into the IT band. And so you have these muscles are agonist-antagonist relationship. And the TFL, you can see it's this tiny, itty, little bitty muscle. It's like the supraspinatus of the shoulder. It's in comparison, right? It's a little tiny muscle, and you can see the glute max. You can see how huge it is, and you would think that if they did a tug of war, that they'd be at an unfair advantage. Well, it is an unfair advantage, and the TFL actually has the advantage. And the reason why the TFL has the advantage is that the glute max is an external hip rotator and extensor, and the reason why it's so big is that it's constantly resisting the effect of gravity. And the TFL, it is the only muscle that is almost a dedicated internal hip rotator. So it's one of the only muscles that would say that internal rotation is its function. And the reason why it's so puny and so teeny tiny is because it has gravity on its side. So it has an unfair advantage over the massive glute max. Now the TFL internal rotation is so minimal that the TFL doesn't only do internal rotation. It does hip abduction a little bit, and it does a little bit of hip flexion, but it shares its function of internal rotation because it's not needed because gravity is there. But the point that we're trying to make here is that this IT band only exists because it's a thickening of the leg fascia that comes from the TFL and the glute max. And why this is important from a practical aspect is you have the sport of running, which is really popular. And if someone's a heel striker, which is an inappropriate gait response, but if they're a heel striker, let's see, I think I saw one of an image here. Well, what happens when you land on the heel, all the forces get transferred up the chain through the anterior part of the foot, through the anterior tibialis, and that's why you'll end up getting shin splints because the force is being transferred there. And then that force continues up through the IT band, and up through the IT band, through the posterior chain to the sarcotubular ligament and up into the spine. And so this transfer of loading, this force, you get a lot of IT band issues with runners. And so you get people that are trying to stretch this all day, right? They're stretching the IT band. Well, the IT band is connective tissue. It's collagen-based tissue. It's like a tendon or ligament. It doesn't stretch, and it doesn't need to stretch. What ends up happening is that you have a motor control issue. You have a length tension relationship with the glute max and the TFL. If you truly are tight through the IT band, it's not because the IT band itself is tight. It's supposed to be tight. It's supposed to transfer loads from the lower extremity through the pelvic girdle. Where the issue's at, it's either in the glute or the TFL. Most of the time, the issue is below the chain, below the knee. It's usually because the connective tissue down here is getting beat up so much because during normal gait or running, the load should be transferred through the posterior aspect of the leg, looking at the calf and the gastroc and the soleus, and not through the anterior capsule of the tibialis anterior. And towards the end of the semester, when we get into gait, we'll talk about the difference between a forefoot strike and a rear foot strike and how that matters biomechanically, functionally through our understanding. But you see, if I think when I pulled up IT band, you'll see nothing more than just like injury, running injury. Like I thought, yeah, pain, right? And it's inflammation. And the reason why it's inflamed is because it's getting too much stress. There's too much load being transferred up the kinetic chain that should be absorbed through the foot complex. But since you're heel striking, it's being transferred up, and this is one of those highways that it transfers through. And so an IT band problem is very rarely an IT band problem. An IT band problem is typically a pronation problem, a mechanical loading. And it's either because the glute is too weak or there's too much force being transferred up through the foot. And so there's weakness one place or the other. But it's ridiculous to think that you're going to stretch the IT band. This is connective tissue, fat leg fascia. Remember, this is just cut out right here. So this fascia goes all the way around and encompasses the entire thing. And so you're not just stretching the IT band, you're trying to stretch this entire leg fascia, and it's not going to happen, right? But again, just as long as you appreciate that when we see this anatomically presented here, that this is nothing more than an anatomical presentation. The IT band really it doesn't exist by itself. It's just a little bit of thickening of the leg fascia, and that leg fascia goes 360 degrees around the entire leg. So anyways, the glute itself has at least half, sometimes more of its attachment into the IT band. And so it can affect a little bit down through here, and the IT band is related to the glute. And this is why when you'll see things like here, appropriate lifting form, so when I say like lift with the legs, not with your back, right? We'll see you guys kind of the OSHA responsibilities. And in my other classes, I make fun of this all the time because usually when they show like appropriate lifting form, they always show it like super wrong. But like, so here, they'll look at this. This is like the quintessential, don't do this, do this. Both of these are wrong, right? These are horrible because when they say lift with your back, not with your hips, or lift with your legs, what they mean really, when you're looking at appropriate lift, this is your biomechanically strongest position if you wanted to load through the posterior chain. And the reason why this is superior is because if I were to draw a line here, let's see here, yeah, I'll just use this image here. I think this is fine. I just want to get a bit, okay, good. All right, so if we start looking at the mechanics here, right now, his foot is flat on the ground. So he's got, let me go back to my color orange here. So his foot's flat on the ground, full contact area, full surface right now. And if we look at his center of mass, he shifted his hips backwards this way, right? So in order for him to do this, if you can appreciate here, he's doing hip flexion. His pelvis is neutral because at least he's trying to keep his pelvis neutral. If we were to look at his pubic symphysis and his ASIS and we look at the rest of his vertebra, he's trying to keep his spine relatively flat through here. So his back is straight, although he's not upright. So there's a big distinction when you look at like keep your back straight versus keep your body upright. When they mean back straight, now I kind of went into the image there. what they really should be saying is neutral spine. And we'll talk more about neutral spine when we get to trunk and spine. But if I were to look at this, he'd have his appropriate curve through the cervical spine, his appropriate curve through the thoracic spine, his appropriate curve through the lumbar spine, and his pelvis is neutral, even though his body is at a 60-degree angle from the horizon, right? So he doesn't have to be erect to have a straight back. He just has to keep his back straight. He's preventing lumbar flexion. And remember, where the pelvis goes, the spine goes, and vice versa. So he's doing an anterior pelvic tilt here. He's keeping that back arch. And in order for him to do that, he's producing a lot of hip flexion. So again, don't think of hip flexion as me bringing my foot up to my body. Think of it also as my body going towards my foot. The other thing that's happening here is you see that he's bending his knee a little bit. And so when you bend your knees, you can either bend your knees this way where the hips go back, and or you can do it, let's see, how do I want to, well, so right now he's loaded through here. There's his load line. There's the foot placed on the ground and his hips went back. You can also appreciate if someone were to bend their knees, they can keep their hips neutral and they can let their knees go forward. And if we go back, let's duplicate this slide. Let's do this. Let's go duplicate tab. And then I'm going to go back one. Yeah, this is a good image here. I use this in one of my classes here, but you can kind of see here that if I compare here and here, you can see that the shin is pretty much perpendicular. And you can see here that you either have to trade off. If you want to keep your torso perpendicular, you're going to have to bend at the knees and let the knees go forward. Right? You can see that the knees kind of went forward here. If you want to keep your shins perpendicular and let your let keep the torso, let the torso bend a little bit, but let it go horizontal, you have to compensate by letting the hips go back. Now, what happens here between a knee dominant or a hip dominant lifting position is you want to analyze which muscle has the biggest capacity to handle load. And if I look at my knee extensors and I look at the total cross-sectional area of my knee extensors and I compare that to my total cross-sectional area of my glute max, the glute max wins all day. And so if I'm trying to lift a heavy load, I want my hips doing most of the work. And then as I brought up last week, we looked at the thoracolumbar fascia. I just realized that I'm on Wi-Fi. All right, so I have my thoracolumbar fascia here, and you can see like I have my glute max coming in here, and I have my lat coming in this way, and then I have the glute max from this side and lat coming this way, and then also in this thoracolumbar fascia are my abdominal wall musculature based on abdominal pressures. And so when I have this huge system where I'm taking my largest muscle in my body, my second largest muscle in my body, and I'm able then to put load through there. If I'm trying to lift heavy things, I am trying to maximize this tissue here, all the thoracolumbar fascia and my largest muscles in my body, my glute max. And so when you lift heavy things, you want to engage your glutes as much as possible. Now, one of the things is that they also say lift with your legs, not with your back. And they say bend your knees. And when people think bending their knees, they think of this position here where they're squatting down to pick things up. What they really mean is this right here. And the reason why this is important is that we said that almost half of the attachment of the glute max is in the IT band. And the IT band is only tense when the muscles underneath there, the quadriceps, they contract. And when they contract, right, you get the sliding filament, they overlap and you get an expansion. And so when you have your knees relatively straight or straight, your quad muscles are flaccid. That means there's no tension through the IT band. When you bend your knees at least 20 degrees, you get tension through the IT band, and now the glute max has a solid surface that it can connect off of. This is why this hip hinge right here is the most important thing people can do. It's how you're able to deal with your environment and bend over, pick things up and load without throwing out your back or putting abnormal stresses from there. So we're usually counteracting the negative effects of sitting for long periods of time And then the other thing is we don't have the appropriate lumbopelvic positioning or even the motor control to learn how to lift things up. And by appreciating that the glute max, the largest muscle of the body, has half of its attachment in the IT band, and its insertion into the IT band is predicated on the tension that's generated there. And that tension can only be generated when you're in this position here, when you have about 20-degree knee bend. Now the glute max is able to fully contribute to whatever load you're trying to pull up. And if I try to squat down and lift up a load, the load's way out here, I'm outside at center of mass. If I try to lift a load and I'm right here, I'm right above it. And the glute right here, this whole lumbopelvic hip complex is doing all of the work. And if you can shift more of the responsibility to the glute, keep the spine in a neutral position to prevent it from torquing on the discs, and you're able to engage your core musculature and get your lats involved, and you minimize the, right, you're minimizing the knee responsibility, so the little tiny quad muscles, relatively speaking, and the glute can do most of the work. This is the best lifting position. And so if you look at this hip hinge position here, and then you compare it to what we were looking at with, like, let's go, like how to lift something heavy off the ground, you'll see that all these images are wrong. Like, that's the worst position right there. That's not a hip hinge, that's a quad dominant, foot's not flat on the ground. Let's look and see what other images we'll see. We can just see that most of them are wrong. Here, wrong, right? Definitely wrong. And again, if I say bend the knees and keep the back straight, this is what we're trying to avoid, because this is also an appropriate position, but this is not the appropriate aspect. The appropriate aspect is keep the back straight and bend the knees, lift at the legs, but you want the hips to do the work, not the knees itself. And that requires a foot flat on the ground so you have good contact. But you'll see, like here, heels off the ground, not a good contact, pelvic tucked under. And I don't know, I'm trying to see if like this, a horrible position right there. But again, this is touted as the appropriate way. And let's see if I can, I'm seeing if I can find an appropriate one. This is somewhat better. Feet are flat. He's kind of doing that, but yeah. But does this make sense? Any questions at all? So your biomechanically strongest position is this hip hinge. And that's why I had said earlier, I think I spend, if I have patients that are back issue patients, or I have clients or patients that have back pain, I spend most of my time just teaching people how to appropriately hip hinge, because this is maximizing the biomechanics and the functional anatomy to maximally distribute the loads to prevent the connective tissue breakdown and put more of the responsibility on the musculature where it belongs. And again, the reason why we got into this was appreciating that the glute max, the largest muscle of the body, where are we at? Right here. It has half of its attachment into the IT band, and the IT band is dependent upon tension through the knee extensors, so the quadriceps, the rectus femoris, and that can only happen at about a 20-degree knee flexion. So when your legs are totally straight, so if you guys were in class, and if you guys want to do this right now, it's fine, but if you were to stand up and grab your butt and bend forward and keep your knees totally locked, your glute, you wouldn't feel any contraction through your glutes at all. Your glutes would relatively stay flaccid because your legs are locked and the responsibility is picked up by your hamstring. But if you do the exact same thing and you just bend your knees about 20 degrees and you bend your knees in a way that your knees stay back, so you're doing, let's see where I got the image at. You're doing this where your shins are perpendicular, not letting your knees come forward, but you stick your hips back. You immediately feel your glutes engage, and now they're ready to do the work, and your glutes are 10 times stronger than your hamstrings. And that's an arbitrary number I'm pulling on my butt, pun intended, because we're talking about grabbing your butt, but it's your glute max that's doing the work, not your hamstrings. And when you can do more of the glute activation, your hamstrings are preserved. And in fact, if you look at why hamstring issues occur, hamstring injuries are usually occurred because we spend so much time in a flexed position, foot forward, femur forward, and we very, very rarely visit that extension. But if you look at how often, like if you think about your squats or your lunges or your leg press and everything, we're only getting to 0 degrees of extension. We're not visiting that 15 to 20 degrees that we normally have. And the only time that you really visit that is through sprinting. So if you look at any kind of sprinting, this is all sprinting from the start here, but you can see here in mid-stride, we're 15 degrees extended, or your book likes to say hyperextended. But outside of all of our training, even bridges that you do and a squatting, lunge, everything, it all goes from flex position to neutral, and we never get into the hyperextended position. So when you have athletes like soccer players or football players that are sprinting, it's only then do you visit that. Like, here's a perfect image. You can see like the upright posture. You can see they're visiting that extension. You only get to there during high speed aspect. If you spend all of your time sitting with your leg forward, and then you only train to 0 degrees neutral, what do you think is going to happen when your glutes need to come on in that 0 to 15 degrees of hyperextension? The hamstring is the one that's used to be using. The body uses a favorable position, and that hamstring can't handle that loading. So it's the hip extension. So the remedy to that is sprint or spend some time doing hip extension activities. But again, it's lack of glute max activation. It's the glute max that is the predicator in there. So if I see someone with a chronic hamstring or adductor pull, we're looking at glutes and glute max to see what kind of strength profile or range of motion, or active range of motion do you have from 0 degrees to 15 degrees. Yeah, so this muscle it's big for a reason, and the body uses it all the time, and it's a common source of dysfunction. All right, and then we're left with the rotators and the adductor muscles. So you have a set of these are all considered the deep external hip rotators, right? You're going to have, there's no internal hip rotators, only external hip rotators, and all these muscles do is they help control the effects of gravity. So not only does TFL exist by itself, and glute max is its antithesis, like its opposite, its agonist or antagonist, you have the glute max has these 7 muscles here, 1, 2, 3, 4, 5, 6, 7, 8 muscles actually. You have obturator internus, externus, you have piriformis. Remember, you have this obturator muscle, you have an internus and externus. This is talking about location and not function. So don't get caught up on an exam where it says obturator internus and you think it does internal rotation. There's an obturator externus, and obturator internus. They both do external rotation. One's internal, one's external. It's on location, not on function. And then you have on the posterior aspect, you have the piriformis, which is just underneath the glute. You have the gemellus superior inferior, and you have a quadratus femoris and obturator internus. Again, obturator internus is on its location, not on its function. So again, not an internal rotator. These are all external hip rotators. Same muscle up here, obturator internus, obturator externus. Just wanted to, I thought I expected it up there. But these all attach on the inside aspect of the greater tubercle, and I don't know if the greater tubercle. And I would look at these as a collective group. I don't know. There's really no functional differences. The only key aspect here is the piriformis, and the piriformis is the muscle that's usually related to sciatic pain issue, because in some people anatomically the sciatic nerve is exiting, like piercing the muscle belly, then it comes out from underneath, and so you can have piriformis issues, tightness that can be putting pressure on nerve. That's the only significant thing with piriformis. Outside of that, they all do the same thing, which if they do isolated function, they're doing external hip rotation, but their primary function is the eccentric control of internal hip rotation, controlling the loading during gait and running activities. And then we're left with the adductor, the glute medius and glute minimus. So the glute medius is the deltoid of the lower extremity. So if you could appreciate the deltoid had an anterior division, a middle division, and a posterior division, you have the same thing with the glute medius, and it does exactly what the anterior deltoid did. Is it did what shoulder abduction, in this case it does hip abduction. Now, just like the fiber arranged, you have your posterior fibers, you have your middle fibers, and you have your anterior fibers. So when you're looking at the glute medius collectively all working together as agonists, you're doing pure hip abduction, so kicking your leg out to the side, or as I shared earlier, on a single leg stance with your right leg posted on the ground, this is preventing the left side of the hip from dropping down, right? So a left hip drop is the same as a right foot going out to the side in terms of pelvic positioning. And so the glute medius is really involved in that when you pick up your left leg, and these are the muscles on the right side. So if we're looking at a lateral view from the right side. If this person were to pick up their left leg, so the leg that's further into the screen, that pelvis, this hip would want to hike up, and what the glute medius is doing is preventing that. It's keeping your pelvis level as you pick up your opposite leg. So your stance leg is the glute medius muscles that are working. Now, outside of that, if I look at like sagittal plane motion, if my leg goes forward into hip flexion, these muscles here will turn on, these division, and these will be antagonists, so these will turn off. If I do hip extension, these muscles will turn off and these muscles will turn on. So you can get separational division. So if I look at my axis of rotation, oops, right there, that's my axis of rotation. Just like with the delt, all of these fibers here are going to contribute from everything. Oh, that's not what I want to do. All of these fibers will turn on, everything from this side, and all these will be antagonists and vice versa. That also means too, when I look at transverse plane motion, my anterior fibers of glute medius can do internal hip rotation. So this is the second muscle we've talked about now that can do internal hip rotation. It's the anterior fibers of glute medius by itself. Not the middle fibers, not the posterior fibers, but the anterior fibers can do internal hip rotation. The posterior fibers can do external hip rotation. So we have TFL now that we talked about that does internal hip rotation, and now we have the anterior fibers of glute medius that do internal hip rotation. So you don't have a whole muscle dedicated to internal hip rotation. It has shared function. And then right below glute medius, so not below like below it superiorly, below it like more deep, is you have glute minimus. So you have maximus on the back, medius that has its attachment. So medius had its attachment here on the crest of the ilium. Right above that, you have your abdominal wall musculature, and then right behind that, you have your iliacus. So glute medius, and then glute medius actually fills in all this area here. And then right below that here, you have your glute minimus. Now, glute minimus is a little smaller, and you can see that it has more of a bias towards the anterior attachment. And so unlike glute medius, where we had a posterior, a middle, and this one only really has two functional divisions. You have an anterior, and then you have either a middle or a posterior. Glute minimus, the anterior fibers, that can also do internal hip rotation if needed, but its primary function is hip abduction. So that's the third muscle that can do internal hip rotation. You have TFL, you have the anterior fibers of glute medius, and you have the anterior fibers of glute minimus. And then the last muscle is that TFL, that tensor fascia lata. And you can see right here the IT band, and you can see here the glute max would have its attachment, its insertion down through here. You have the TFL that has 100% of its attachment into that. And this comes down and it attaches right past here. So this actually crosses the knee. So in some aspects, you can argue that glute max and TFL can produce knee extension. And really all that's showing is that you have this highway, this anatomy train, or this fascial highway that the glute max is involved from lower extremity type activity. And then you see this picture here, which shows the contralateral glutes, glute medius, these abductors, glute minimus, glute medius, glute max, and TFL, that when I pick up my opposite leg, those muscles are there preventing that hip drop. Right? So if I have weakness through here, you're going to see a shift of the body weight to kind of regain that center of mass, and you're going to see this hip drop down this way. And that normally when you pick this up, you're going to see a little bit of a lean this way, but not as pronounced, and that your pelvis is going to stay relatively stable because these muscles on the opposite side are preventing this hip from dropping down. So you can kind of see here, you can appreciate the way these muscles all come together here. There's the iliacus and the psoas converging down. They're coming underneath the inguinal ligament. Here's your pectineus. your adductor longus and brevis underneath. Here's your sartorius muscle, the more superficial. There's your TFL coming down to the IT band. You can see your adductors pulled away to kind of reveal the adductor brevis and the adductor magnus. Here are your adductor fibers. There are your vertical, your hamstring fibers. You can see the three muscles here, the gracilis and the sartorius was kind of cut away, and the semitendinosus is also there. So yeah, it's kind of a cool. You can see your glute medius popping out a little bit behind the glute max. Your glute max is more posterior. And I think that is it. I think the only thing we didn't talk about were the hamstring muscles, but I think we'll, yeah, I guess, did we skip it? Where are the hamstring muscles at? We just go up. I think there was some of the hamstring. We'll talk about the hamstring mostly in the knee aspect, but the hamstrings do operate as knee extensors. Here we go, right here. So you have your semitendinosus and semimembranosus. Your tendinosus has the longer tendon. That's why it's called tendinosus. This is the one that comes along and attaches in the front of the tibia, part of that pes anserine. If you have an ACL reconstruction, this is the tendon that they harvest. I would not agree with that. I wouldn't harvest any kind of functional muscle tendons. The other option is the cadaver Achilles, which kind of sometimes has a higher failure rate, but the semitendinosus is the muscle they harvest. It crosses the hip and the knee, so it's a hip extensor and a knee flexor. The semimembranosus, right here, this is the more medial, so always think membranosus M, the medial of the two muscles. It is a more flatter of the two, but it attaches down here towards the posterior aspect of the tibia. And then right here you have your bicep femoris, and it is like the biceps brachii, but now it's the bicep of the leg. It has two divisions, a long division, short division. The short division is not talked about here because the short division only crosses the knee, so it's only a knee flexor. But the bicep femoris, like the long head of the bicep of the arm, it like it flexes the shoulder and the elbow. This also has two functions, but it extends at the hip and it flexes the knee. So you have bicep femoris long head right here, and then you have the short head, which we'll talk about in the knee unit. But the short head here, it originates down in the linea aspera here, and it also attaches. It has the same attachment site there on the fibular head. So that's it for the musculature of the hip, all related to the hip. We broke off into a tangent about the Trendelenburg and functional positioning. We looked at the ligament structure in terms of hip replacement. So from medical conditions, I would definitely kind of know the posterior hip precautions and what you can and can't do and what ligament structures are involved. And then from a functional perspective, we looked at a lot of the musculature there from its aspect and some of the significant attachment and interrelationships that exist there. And then as we progress through the knee, we'll look at some of the interactions between the biarticulate muscles like the hamstring groups and the rectus femoris. And when we get into the trunk and spine, we'll talk more about like pelvic positioning, pelvic neutral, and revisit some of that again. Any questions at all? So a little bit long session today, but luckily it was recorded. Oops, just lost my